I'm Christy Dunst, esophageal surgeon at the Oregon Clinic, sitting here with Dr. Ashwin Kurian, here to discuss his new paper, Oral Endoscopic Myotomy, Defining the Learning Curve.
We thank the Journal of GIE Endoscopy for the opportunity for presenting our paper in the form of this interview.
Dr. Kurian, can you first tell us what is POEM and what's the significance of this as a new procedure?
POEM is a short form for per oral endoscopic myotomy. It is a new procedure, an endoscopic procedure for the management of benign esophageal disorders, classically achalasia. It's a procedure whereby the endoscope traverses through the submucosal tissues of the esophagus and divides the inner circular muscle layer of the lower esophageal sphincter without any incisions on the abdomen. The potential is that it's an exciting procedure which has the potential to be the gold standard in the future once we get more experience and long-term outcome data, but the short-term outcomes are extremely exciting.
Now, what inspired you to write about the learning curve?
So when I initially applied for this fellowship, I was very excited to know that this was one of the few centers in the United States and even in the world that performed this procedure, and I was very excited when I started my fellowship to train to do this procedure, which opened my eyes towards therapeutic endoscopy. And towards the end of my fellowship, I thought I should try and summarize my experience training to do this new procedure. So that's the reason, that was the inspiration behind writing this paper.
And how did you choose your benchmarks for the learning curve, such as length of procedure and inadvertent mucosotomy?
So length of procedure is a metric that's been used in various studies to look at competency and efficiency of a procedure. And inadvertent mucosotomies have been used in other studies that look at the learning curve associated with laparoscopic myotomy. And interestingly, we found other complications such as pneumomediastinum, or pneumothorax, or pneumoperitoneum not related to any place in the consecutive place in the learning curve. But we found that length of procedure and inadvertent mucosotomies had a trend relation to the learning curve.
So why didn't you use clinical outcome as defining of the learning curve?
Interestingly, all these patients do extremely well from their swallowing standpoint. In fact, in our initial experience, we feel that they have a faster return of their swallowing function as compared to our experience with the laparoscopic myotomy. I think long-term data regarding reflux and objective evidence of reflux may be a future way of seeing whether that's related to our learning curve. But our initial experience with the swallowing had no, because all the patients did extremely well, we didn't correlate that with anything to do with the learning curve.
So it sounds like length of procedure and inadvertent mucosotomy is technical markers of proficiency in the procedure. Dr. Kurian, how does somebody train to become proficient?
So our protocol at the Oregon Clinic and the Providence Portland Medical Center to train fellows and visiting participants to our POEM courses is first to make sure that they have a baseline didactic knowledge about esophageal physiology and pathology, followed by familiarizing oneself with all the instruments, the endoscopic instruments, followed by working with porcine explant models, which I feel are cheap and easily accessible, and give participants and fellows an opportunity to perform the procedure again and again and become comfortable with it. After this, we move on to live porcine models in the lab, and following this, the participants and the fellows become familiar with the environment of the operating room, recognize anatomy, and watch the procedure. This can be supplemented by watching videos, multiple videos of the procedure, and recognizing variations in anatomy. And I think after this, it's important that you're proctored in your first few cases while you actually perform this procedure with somebody who has the experience of doing POEM and is comfortable with managing complications in POEM and complicated cases.
So, in general, I think anybody who is interested and technically proficient in interventional endoscopy with an understanding of esophageal motor disorders would be qualified to do this operation after a certain set of training courses and lab experience. What do you think then is the future of the procedure?
I think the future is extremely exciting. I think we are at a cusp of a new era in surgical interventions where surgery is becoming less invasive and moving from the laparoscopic era to the flexible endoscopic era. And with this procedure itself, I think it's important to get all the information in the long-term outcomes, but presently just being able to predict and look out there, it seems extremely exciting, and it has the potential to replace the laparoscopic helomyotomy and and achalasia balloon dilations for achalasia in the near future.
So one last question for you, Dr. Kurian. You are the Notes Fellow at the Oregon Clinic and Advanced Flexible Endoscopist. This has been touted as the most successful application of natural orifice surgery, flexible endoscopic surgery. Do you see us taking it a step beyond? Do you see us using this tunneling technique to reach difficult places in the mediastinum, or using it to access the abdomen at all?
I think the new lessons that we have learned from notes, especially from the POEM technique, have opened the possibility of not only reaching different organs in the mediastinum, but also various organs in the abdomen through this technique. And our fear for traversing luminal structures and going extraluminal has decreased. A lot of the old dogmas of surgery are being replaced by new understandings of postoperative physiology. So I think the future is extremely exciting.
Well, thank you very much. Thank you, GIE.